Dr. Pranab, sir.
Thank you, Dr. Suraj, and I, on behalf of ISOC, welcome you to the 15th episode of Voice of East of the current edition. So this is for the last 4.5 years that we are having this Voice of East program. And today's topic, we have PCR management, which is very, very practical and useful, and a lot of tips we are going to get from the speakers, panelists, and chairperson. Today's speakers, we have Dr. Abhishek Anand, Dr. Jayashree Barua, Dr. Sneha Jain, and Dr. Subhas Prasad. I would also like to welcome today our international guest faculty, Dr. Lalit Agarwal, our invited national faculty, Dr. Arup Chakravarti, and Dr. Deepak Meghur. The webinar will be moderated by Dr. Shishi Shekhar Singh and Dr. Anurag Mishra. And in the panel, we have Dr. Salabh Sinha, Dr. Rajesh Agarwal, Dr. Ashok Nanda, and Dr. Sujay Samanta. The chairpersons being Dr. Amit Raj, Dr. Anand Dev, Dr. Amitav Biswas, and Dr. Tane Natung. I also express my gratitude to the program coordinator, Dr. Debashish Das, and Dr. Abhishek Anand, especially Dr. Debashish Das, who has been doing a wonderful job in having the webinars regularly every month. I'm also indebted and express my gratitude to the General Secretary, Dr. Suraj Bhattacharya, the Chairman Scientific Committee, Dr. Sabyasachi Patnaik, and the rest of executive members for giving full support to us. Last but not the least, I welcome the audience, and let us have a great learning evening. So with this, it's over to Dr. Debashish Das, the Chief Coordinator of the program.
Thank you so much, sir.
Carry forward and
thank you so much, sir. Thank you so much for your kind words. Actually, the whole philosophy behind the Voice of the East, when Dr. Pranav Ranjan was the secretary and I was the chairman scientific committee, we decided that there should be a platform where we should highlight and we should encourage the younger generation of speakers from the Eastern Zone, and that is the whole philosophy behind the Voice of the East, and it has gone from bounds to bounds, and now it has not only encompassed the Eastern Zone, but it also encompassed the national faculties and now the international faculties as well. So I think we are happy that it is going in its correct directions. With that, may I hand over today's session to our moderators, to our brilliant, two young and energetic moderators to man the show. Dr. Singh and Dr. Anurag, please.
Good evening, everyone. Thank you so much, Dr. Debashish sir, for giving us this platform and this opportunity. I would like to start the session by introducing our chairpersons for the evening today. Dr. Amit Raj sir is the professor and head projects to his name. Our second chairperson for the day today is Dr. Anand Dev sir. He is the director of Eye Care in Bhagalpur. Sir has been an ex-consultant at Arvind Eye Care and has performed multiple life surgeries. Dr. Amitav Biswas sir is the founder and director of Sunitra Family Eye Care Center in Kolkata. Sir is an alumnus of the prestigious CMC Vellore and AIMS New Delhi for his graduation and post-graduation respectively. Sir is also an ex-fellow of the prestigious Yale and Wills Eye Hospitals in the United States. Dr. Tane Natung sir is the professor and head of Northeastern Indira Gandhi Regional Institute of Health and Medical Sciences in Shillong. Sir is an alumnus of the prestigious JIPMER and AIMS New Delhi for his UG and PG. Sir is also an ex-fellow of the Wilmer Eye Institute, USA. We also welcome our international faculty today, Dr. Lalit Agarwal sir, who is the medical director at Viratnagar Eye Hospital. Sir has performed thousands of vitreoretina surgeries. We have our national faculty, Dr. Arup Chakrabarti sir from Trivandrum and Dr. Deepak Meghur sir from Bidar, Karnataka. Dr. Arup Chakrabarti sir and Dr. Deepak Meghur sir, they don't require any introduction. In our panel today, we have 4 panelists. Dr. Salabh Sinha sir. Sir is an eye surgeon at Nayandeep Netralaya, Muzaffarpur, Bihar. Sir has authored multiple books. We have Dr. Rajesh Agarwal with us, who is a vitreoretina and phacosurgeon at Buddha Eye Care, Patna. He's an alumnus of the prestigious RIO Kolkata with vast experience in the field of cataract and retina surgery. We have Dr. Ashok Nanda sir, who is a cataract and refractive surgeon and medical director of Car Vision Eye Hospital, Bhubaneswar, and Dr. Surya Samanta sir, who is running a NABH accredited eye hospital at Hazaribagh, Jharkhand, and practicing phaco, glaucoma, and comprehensive ophthalmology. Now we can move on to our talks for the evening. The first talk by Dr. Abhishek Anand sir. I would like to hand over to Dr. Anurag Mishra sir to take over from here, and we can go ahead with the sessions for the evening. Dr. Anurag sir.
Okay, thank you, Shishir, for the nice introduction of everybody present around here. Good evening, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. As we get underway through with the scientific session of the evening, here in comes the first speaker of the evening. He is working in the capacity of Associate Professor RIO IGMIS Patna at the moment. Dr. Abhishek Anand is a vitreoretinal surgeon, and I was just going through his accomplishments scientifically, and there are loads to speak about it. But I'll just give you a gist. He has got 15 index publications. He's a co-author and co-researchers in the phase 1 and phase 3 clinical trials of things. He was the first to do macular buckling, suprachoroidal buckling, suprachoroidal therapeutics in the eastern part of India. So to speak, he is a prolific vitreoretinal surgeon, to speak the least about him. In comes Dr. Abhishek to speak about the PCR management for anterior segment surgeons. Dr. Abhishek, over to you, and the audience is waiting to hear from you over the next day.
Thank you, sir. Thank you for a very kind and generous introduction. I hope I match the energy of your voice, sir. So are my slides visible?
Perfect.
Okay. So I would be speaking on management of PCR on a platform that we know how to address, but to be addressed by an anterior segment surgeon. So to begin with, PCR is a known complication. It can happen in the best of the hands, and successful implantation of the IOL in bag or sulcus with complete removal of the lenticular matter and vitreous gel should be our goal in the same sitting. Many alternative techniques currently exist, which gives almost same results as an uncomplicated phaco. And this is the most important thing, that even if a PCR happens, we can give the patient the best of the results. And a badly managed PCR should be best avoided at best time. And what is the game changer? The game changer can be the early identification of a PCR. We all know sudden deepening of the anterior chamber, sudden transitory appearance of a clear red reflex, inability to rotate a previously mobile nucleus, loss of nucleus followability, tipping of one pole, or descent of the anterior nucleus into the anterior vitreous. You should get a warning sign that there is something going on. And at that point, early you recognize, the better the outcomes would be. So what are the goals of the management of a PCR? Avoid posterior dislocation of the nucleus, minimize collateral damage to the corneal endothelium, prevent enlargement of the tear, and prevent damage to the capsulorhexis. And this is one of the very important things, that whenever we are managing a PCR, this capsulorhexis more generally is intact, and we can place the IOL in the sulcus and avoid an SFIL or iris fixated IOL. Avoid traction to the peripheral retina and avoid peripheral breaks. Removal of the leftover cortex, because cortical matter left can cause a lot of inflammation. Proper positioning and centration of the IOL is must. Now, what are the management strategy? Management strategy depend a lot on the extent of the PCT, intactness of the hyaloid phase, whether the nucleus is dislodged into the vitreous cavity or you have been able to retrieve it in the anterior vitreous. Availability of the equipment, that you do have access to the vitreous cutter, vitrectomy machine, and a vitreoretina surgeon, and availability also of the alternative IOLs if required. Urge of sudden removal of instruments should be best avoided. Unplugging of the incision will result in emptying and collapse of the anterior chamber, negative pressure, and the vitreous will prolapse more. Anterior chamber should be filled with a viscoelastic through a side port incision to block the vitreous prolapse and stabilize any remaining lens material prior to removal of the phaco or the irrigation aspiration handpiece. Now, if you are doing a phaco and you get a PCR, the surgeon should stay in the foot pedal position 1, and as the viscoelastic is injected, it should change to foot position 0, and the handpiece can then be safely removed after the anterior chamber is filled. Look at how beautifully this is managed. You see, the viscoelastic is injected before the removal of the phaco tip, and then we can proceed with the cutting of the prolapsed vitreous. Look at the vitrectomy cutter introduced to the side port, and it just at the sitting on the top of the posterior tier, and then we can proceed with it. Now, in order, the other principles are to you can use a dispersive viscoelastic. So can be used to plug the posterior capsular tear. Nuclear material is moved into the anterior chamber with a spatula or emulsified with a salt burst. And you use a low parameter, low portal height, low flow rate, low vacuum, and low ultrasound, and avoid fishing. Avoid fishing. We get a lot of cases of a well-managed, well done PCR, but some suction, some tear, and that causes a peripheral tear, and the patient after 1 month, 2 months, or even years gets to a retinal detachment. Look at this case. So in this case, the surgeon notices a posterior capsular tear. And why did it happen? Because there was not an epinuclear plate protecting the posterior capsule. So the posterior capsule came and hit the tip of the phaco, and you got a tear. Now see how the surgeon goes and manages it. He had left the epinuclear plate or the nuclear shunt into it and uses a IOL as a posterior scaffold. So he introduces the IOL beneath the epinuclear and some amount of nuclear plate, and now it can be used as a posterior scaffold, and then you can proceed with the completion of the phaco, and then eventually do all. So once you have done this, so this posterior scaffold of IOL is acting as a scaffold on which you can complete your phaco and get about with it, and totally very wonderful results. So this IOL acts as a scaffold. It will not allow the epinuclear place to fall down, and then we can emulsify the whole of the nucleus, and then we can proceed with the completion of and removal of the rest of the cortical matter. And now this is one very important step. In this, what we are seeing is that the surgeon is using an irrigation tip and using the vitreous cutter as to remove and aspirate the cortical matter. This will be further emphasized in the rest of the slides. Now, how to perform anterior vitrectomy? Anterior vitrectomy should be performed so as to allow closure of the wound without vitreous incarceration. Secondary removal or dislocation of dislocation through three-port pars plana vitrectomy. What are the parameters of anterior vitrectomy? A lot of residents go and ask me, so use the maximum possible cutting rate, whichever available is at your machine. Vacuum should be around 200 to 250 millimeter or 300 millimeter of acid, and low flow rate. The vitrectomy tip should be inserted through the opening in the posterior capsule and placed a millimeter or two behind the posterior capsule. The aspiration port should be directed upwards towards the cornea. Now look at it. There are two methods of doing it. Once you are above the posterior capsular tear, and one is below the posterior capsule. Once you are above the posterior capsular tear, then you are sucking more vitreous into that space. But once you are just beneath 1 millimeter behind the posterior capsule, you are sucking the whole of the prolapsed vitreous behind, and you get the you cause less prolapse of the vitreous molar. Begin the vitrectomy dry and then infuse VSS gently. More vitreous will prolapse if the pressure in the anterior chamber is low when the aspiration continues. The vitrectomy step should not be placed through the primary phaco incision. And this is very important, that you should not use the primary phaco incision or for inserting of the, and never change the vitreous. Vitreous is gel, it will automatically come. Look at this, another case. So in this already, my JR already, there's a small PCTR. You can note they have patient, the JR has, SR has already established the three-port. I asked stop and then proceed with. And this is very important, that you should have access to a vitrectomy cutter, which you can control the suction as well as the cutting rate. So in this, since already the three ports were established, I went through the pars plana, but that is not at all required. You can use the limbus two side ports to introduce, which we'll see in the coming part. So I go and insert, and so this is, I'm using the infusion, and then I'm using the vitrectomy cutter as an alternate cutting, as well as I'm using it as an aspiration also. So I first of all remove the vitreous, then I close the vitrectomy, and then I use it as an alternate aspiration. So I use the vitrectomy cutter to suck the cortical matter, and then once I feel that some amount of vitreous is coming, then I use it as a vitrectomy to complete the vitrectomy. And this is one of the best methods that I feel, that if you use the combination of irrigation as well as vitrectomy cutter to aspirate the cortical matter, which will have the least amount of peripheral traction to the periphery of the retina. Now, this is a typical case scenario which I would like all to do. Now, this is a case in which I was bought when the drop nucleus has already happened. But what is CBC? We see that there's a very good rhexis. And this is what I would advise to everybody, all of you, that once you have a very good rhexis, if you have access to any IOL, preferably a multi-piece IOL, then you place the IOL in the sulcus. Once you have placed the IOL in the sulcus, and then you can suture the main port. And this suturing of the main port is one of the very important steps. And then you can refer the cell for the further management. And if you have access to a VR surgeon, you can manage it at that point of time. So once we have put the IOL, I go behind, and then I use the same step of vitrectomy, using vitrectomy cutter to cut the vitreous as well as to aspirate the cortex. You can't leave these cortical matters, otherwise they will cause long-term, very subtle sort of inflammation, and the patient will keep complaining. So all these cortical matters need to be removed without compromising the capsular integrity. So this is used as an alternative. So basically, I am able to control the cutting and the suction alternately, and I use it to remove all the cortical matter. And this will give me a post-operative ultra quiet eye. I don't want any inflammation post-operative. So once I have completed and complete removal of the whole of cortical matter, then it's the usual steps of retina surgery that you go behind and do a PVD induction, and then you complete the removal of the drop nucleus. In this, I also attempt to do an optic capture of the IOL, because I feel that the capsular rim, if it entangles the optic rim, then it causes less irritation of the iris. And then we proceed with the usual procedure that we complete the removal of the top nuclear matter, do a peripheral indentation to look for any peripheral breaks, and then complete the surgery. So to conclude, so one of the most important is to identify the presence of predisposing factors and appropriate modification of the surgical plan preoperative. There is this is the best time where you can address it at that point of time itself. And if you have any PCR intraoperatively, do not panic. Early recognition and treatment of capsular tear and vitreous loss prevents serious complication and improves post-operative outcome. Take time to ponder. Just stop the surgery for a few seconds. Take time to ponder what should be the best surgical strategy in an extent of PCR. In cases of doubts, discussing intraoperatively with colleagues, mentors can have long-term implications for the patient as well as for your peace of mind. Take help of retina colleagues whenever required. And one of the most important things is to discuss PCR with your patient post-operatively and explain the intraoperative and future management strategy. And this is the most stuff which I think is lacking somehow among us. So in the end, do what suits you the best. Thank you. Thank you for listening to my talk.
Thank you so much, Dr. Abhishek. You can stop sharing your slides, please.
Yeah, I will just do that.
All right, to begin with, I'll just take one point from the final slide of yours. Do you think it's a good idea to discuss with your colleagues intraoperatively while the patient is lying and the PCR already happened and you...
No, I'm not talking about you, sir. And when I wrote that line, it was for a person who is still in his learning phase. For an experienced surgeon like you, you don't require any advice. You can advise one of us. That is for persons who are, suddenly you have something and you don't know what to go about, and you are still in your learning phase. You can just stop. Don't discuss in front of the patient.
Exactly.
Yeah.
So I was actually talking about the same thing. Don't tickle the auditory senses of the patient while discussing anything intraoperatively. Very nicely highlighted points, though. You did highlight and emphasize on the closed chamber technique of vitrectomy using the two side ports and not doing it through the main port. I'll bring in Dr. Arup here. So there's a question that I have in my mind. There has been a lot of talks of pars plana vitrectomy for anterior segment surgeons off late. Is it something that just decorates talks on the podium, or it's also got some relevance and all of us should learn how to do a proper pars plana vitrectomy, or an anterior limbal vitrectomy is also as good as the other one?
I think the talk was quite nice, Abhishek. Congratulations. And Thanks
Thank you, sir.
for involving this. So basically, I think a surgeon should be familiar with both the techniques. It is not that I am an expert in bilimbal vitrectomy and I'm an expert in passman anterior vitrectomy. So you should be familiar with both the techniques, and you should actually learn how to do a passman anterior vitrectomy, uh, not from your first few PCRN cases, because PCRN has already occurred, the eye is soft, and you do not know how to use the trocar cannula, how to go through the pass planner. So it requires some wet lab training. It requires some real training when you work with a colleague or see your VR surgeon. I mean your VR colleague, and let him give an opportunity to do pass planner procedures, pass planner anterior vitrectomy. Otherwise, if you do bilingual vitrectomy also, but the technique that you have described, then that is also pretty well. So you should not start the vitrectomy from the anterior chamber where, more and more vitreous starts coming and there is stress on the PC rent area, and the PC rent keeps enlarging. So I think a surgeon should be familiar with both. 2 points I wanted to add here. Number one is in triamcinolone acetonide. If you had moment to suspect the occurrence of a PCRN, it is always useful. I mean, I would say it's mandatory that you try to stain the anterior chamber with triamcinolone acetonide. So that gives you a good idea as to whether vitreous disturbance has occurred, and where exactly, how much vitreous has come, where exactly it is located. So it can let you do a very controlled vitrectomy. And I think you have quite adequately emphasized the role of suture closure for these incisions when there's a PCRN and when vitrectomy is done. But if you're not using intracameral antibiotics, I don't use in a routine manner. But in cases where I've had a PCRN or a zonal dialysis, I'd be using intracameral moxifloxacin prophylactically. So I think that is another take-home point that I thought I should emphasize. Both emphasize in this particular discussion. Otherwise, it was a very nice presentation, good videos.
So you mentioned everybody should be familiar with the pars plana vitrectomy, but do we use the same phaco machine just in case we don't have access to a vitrector? Do we use our phaco machine vitrector handpiece to do a pars plana vitrectomy? Do you think the cut rate is good enough to go into the core vitreous and do a vitrectomy there?
See, when we talk about high speed, high cutting speed, we are not talking about cutting at a speed where what is used by a retina surgeon when they're working very close to the retinal surface, ERM peeling and things like that. So when you say you use the highest cutting rate, and you need to say that this is an anterior segment machine, an anterior segment machine will not give you a high cut rate like 8,000 or 10,000 or more than that. You don't really need it. It slows down the whole process. So I would say that, I mean, for a standard machine, maybe 2,000 to 4,000 cuts per unit time, I think that is a good idea. You don't really have to go at a very, very high level. I incidentally use a posterior segment machine when I have a vitrectomy. Both the machines are kept on standby because PCRN complication, it is not a very common problem. So once you use an anterior segment cutter, a 23 gauge cutter, and the next time you use it, if you have not maintained it properly, not cleaned it properly, you find that it doesn't work. On the other hand, the posterior segment machine, the cutters which are used along with those machines, they are kept they are always, they never go out of circulation. They're used on a daily basis and they're properly maintained.
Quick comments from Deepak Bhai and Dr. Lalit on the same issue, and then we'll open the session to the panelists if anybody else has to offer any comment. Deepak Bhai?
I think very well presented, Abhishek. Regarding the pars plana approach, I would say that, if you don't have access to the trocar and cannula, and even without a trocar and cannula, we can perform pars plana, the anterior vitrectomy. I would rather prefer this simply because, it is quite challenging for an anti-segment surgeon to go and change the direction and enter, especially for a beginner, because the eye would be soft. The eye already is open, it's soft. So it's a little bit, rather than that, just take a MVR blade, 20 gauge, directly just go in, and then you do the vitrectomy cutter with your 23G cutter, which comes with your anterior phaco machine. It does the job very well. Only thing, you put a 8 of acrylic suture and that's it, the job is done. So this is much more safer, I would say, for a cataract surgeon who is venturing to do a pars plana vitrectomy for a PCR. It has got lesser side effects, lesser complications. The only price you're going to pay is to put that additional atovicril suture and maybe do a peritomy. But I find this is much more safer. The other tip would be when you go inside, you should visualize your tip through the poster caps across it. You know where it is, and you can see it well, so that you don't want to, inadvertently hit at the poster caps or other things. And then you can do it in a very controlled manner. The other habit which most people have is just go around searching for it. You shouldn't do that. Just be stable. Just be stable and keep cutting it. And then in a matter of a couple of minutes, I think the job is done. So as Arup sir was telling, I think it's helpful for a cataract surgeon to be well versed with both the techniques. And believe me, it is not very difficult to do a pars plana vitrectomy for an efficient phaco surgeon. It's just a matter of mental block. Once you get over it, you can do it. And at the same time, you can achieve equally good results by using your limbal route as well. So it is not mandatory that you always have to go to the pars plana region. Only a few certain specific case scenarios you would want to do it. For example, you have a zonal dialysis where you want to reach the posterior part. That is a better idea in certain situations, but not always. In majority of the cases, you can achieve equivalent good results just by going through a limbal region. The reason is when you want to do a pars plana, you have to again augment the anesthesia. You are doing under topical anesthesia. So a little bit extra procedures will be there. So, but as Arup sir said, it is better to be well versed with both situations, and it is not so difficult as one perceives it to be.
Thinking
I just wanted to add one point here. When you want to do a pars plana anterior vitrectomy, there are certain situations where deep set eyes, very big nose. You cannot really access the area where you want to cut the vitreous. So invariably, I have to come only in those limited cases where you have to come from the limbus for ease of access to the vitreous. In fact, I have seen people who are big proponents of this concept that do everything to pars plana. They have left vitreous strands behind, and they have come to the limbus and done the anterior vitrectomy from the residual anterior vitrectomy, where supposing there's a lens in place and there's a PC lens, there's a vitreous. How are you going to access a vitreous strand which is already going to the paracentesis section? Is very difficult. So in those situations, you need to also remove the vitreous strand and do some amount of cutting through the limbus. So it is basically the surgeon's decision, his wisdom, and proper vitrectomy technique. I think that
another reason why I would urge the anterior segment surgeons to at least be familiar with the pars plana route is, apart from all the other advantages that we have been discussing for the last couple of minutes or so, it also gives you the access to the sinking nucleus. In case it is sinking, you can levitate, you can support the nucleus from the pars plana route. All right, Dr. Lalit, you agree to most of the things that we've discussed here, or you've got a different opinion to offer?
Well, as far as pars plana vitrectomy is concerned, first of all, what in my personal experience, what I have seen is, in the initial few years, as an anterior segment surgeon, we are striving to manage the anterior vitrectomy part by the limbal approach itself, because it's not just the anterior vitrectomy at one particular time, but it all depends upon the stage which Dr. Abhishek just discussed, at which step we have encountered the PCR. So the multiple times we have to do anterior vitrectomy, that might not be able to be managed by the pars plana approach. And there are only people who have been doing both anterior segment surgery as well as pars plana vitrectomy on a regular basis, who will be able to manage all the difficulties and multiply going from anterior approach and by pars plana approach in between. So what I feel is, it is not easy for the anterior segment surgeons to take up into pars plana vitrectomy in the initial phase.
It's not very difficult as well.
Yep.
So I would like to just add a point here. We recently had a similar case. So you just, Anurag sir just mentioned that pars plana approach can help in elevating a dipping nucleus. That being one point. Two more points I would like to add. One is procuring a infusion through pars plana route is sometimes easier compared to getting an AC maintainer. The AC maintainer keeps clipping, we feel, at multiple times. And infusion through a pars plana route, even if put by an anterior segment surgeon through a trocar cannula, will have lesser chances of slippage. And we recently had a case where an IOL was dipping. If the sulcus is good and an IOL is dipping with one haptic still engaged somewhere in the bag, then going through the pars plana route, even if we are not a proliferating, a full-fledged vitreoretinal surgeon, can sometimes just push the IOL upwards. And we might not need to do a complete vitrectomy. We can just go in through a limbal incision with a retinal forceps and pick that IOL and place it in bag if possible, or in sulcus if possible, without having to do a complete vitrectomy in such a case. So this situation can be helpful for anterior segment surgeons, also in a case of a dipping IOL with one haptic still somewhere in the capsular area. Does not require.
Sure. And Anurag sir, I think I completely, somehow take a different route. Approach to this is that, see, the point is that whatever said and done, all these things like putting a trocar, putting an infusion cannula at a pars plana, until you are well versed with, you can create a catastrophe just by doing all these things. You can just create a catastrophe which was never there. So overall, what is the principle of management is to not do any inadvertent damage until you are very, very sure, and until you are regularly doing this, putting the trocars, cannula, inserting the base, looking for it. We are not talking about Dr. Deepak Megoo sir or Dr. Avinash Mishra sir, that they might be doing every day, but for a take-home message for an NTS segment,
which means we land up in a PCR every day.
No, that is the point, sir. So it's not a usual complication, and you should not do it, because for putting a trocar as well as these can create a lot of other damages. Just inserting the most important complication of uncomplicated vitreoretinal surgery during the days when the trocar was not present was to create a small breaks at the base when you're introducing the the cutter itself. So we should be, I think, when you can achieve a very good result with a bilimbal route, why unnecessarily venture into a pars plana route? That is until it's very much indicated. That is what I'm saying.
Anurag,
120 seconds left before we close this section. Quick comments from the panelists, please. I invite you all to chip in with comments.
One opinion from my side.
Yes, sir.
Definitely learning pars plana is a good skill to learn for an anterior segment. It will be a feather in the cap for the anterior segment surgeon, because most of the time these limbal route vitrectomy, they do work well in a closed chamber, but one can land in a SOP if one does not know pars plana. There can be chances, say 1 in 100 or on those times. So definitely trained and an expert anterior segment surgeon should learn the skill of pars plana vitrectomy. Though it's tough, I agree, and there can be catastrophic complications also.
Anandev sir, seeing you after decades.
I think whatever the surgeon is well versed, he should try it. Because PCR nowadays is very rare, almost like 3-4 months time one gets a PCR. And so he should do whatever the surgeon is comfortable with.
Any other comment? Oh, sorry, sir. Yeah.
Otherwise, everything has been discussed very.
Yeah, it was a fantastic presentation indeed. Any other comments, or should we move on to the next segment?
Yeah, Dr. Anurag, one more thing I would like to highlight.
One thing I would like to point out, there should be a wet lab training for pars plana vitrectomy. Otherwise, what Abhishek said, I totally agree with that, because the limbal route also works very well. I mean, a lot of cases, 5 years, 6 years down the line, even 10 years down the line, they are behaving nicely. So if nicely done, I think the anterior segment surgeon.
If anybody disputes that, sir, it's a each to its own kind of a.
No, I know, Dr. Pranav, this wet lab
training for the anterior segment surgeons, so that they get versed to it before they start doing it or trying it.
If I have to augment to what Dr. Pranav had said, I did a wet lab training in the early 2000s in one of the ASCRS meetings through the pars plana. Initially, of course, it was just, we didn't have a good concept about how to do a bilimbal vitrectomy. But I think 2000 or 2001, I did a wet lab, pars plana anterior vitrectomy. Then I came back, then I assisted, my wife is a VA surgeon. So I assisted her for some cases. And then, I gradually for the routine vitrectomies, how to make a sclerotomy, how to handle the trocar and cannula. So I think it should be done in a very planned manner. If you plan it out, you just make sure that you do not, as I already mentioned earlier, that it should not be a first pass plan anti-vitrectomy in your PCRN scenario. It should be you should have done it gradually, and then do it. I think Deepak also mentioned that point. And you can just do an MVR sclerotomy directly. You have to just suture it. That's it. But
the book that's open in front of you, if it doesn't contain the CV of the next speaker, then open your phone, find out the CV, introduce her, and invite her to the next talk. Thank you.
The next speaker, Dr. Jayashree Barua, Madam, who's the Medical Director of Sight Plus Eye Care Center, Jorhat, Assam. She has her next talk. We invite Dr. Jayashree Barua, ma'am, to share her slide, please.
I hope my slides are visible, and am I audible?
Yeah, you're audible. Your slides are visible.
Okay, thank you so much. I hope the network doesn't create an issue today. And at the very outset, I would like to thank the entire ISOC committee for making me a part of this webinar today. So today I have been asked to speak on the tips and the tricks for iris fixated IOLs, how to start it in your practice. Now, as we are all aware, PCR is not an uncommon thing, but sometimes what happens, sometimes we may get situations where there are no capsular support as well. So in these cases, what do? So it's better to go for the most comfortable option with what you're most comfortable with. You have the implantation, you can go for implantation in the anterior chamber, which I never have tried, and I don't somehow prefer this technique of ACIOL implantation. And you have the posterior chamber implantation, be it the retrofixated iris or you have the SFIOL. And if you're not versed with these two techniques, go ahead with the third option, that is refer your case to your retina colleague or to a colleague who is apt in doing such cases. So AC, we know that the anterior chamber is not the best place where you place a foreign body which has some micro movements. So definitely SFIOLs are preferred, which is the next talk in our session today. So these SFIOLs, but they have a long learning curve. It is a bit of a complex procedure. You require more instrumentations, and there is the risk of associated complications if you don't do it well. So is there a safer alternative? It is here then when I came across the iris claw lenses. As we can see the picture out here, it looks exactly as like your PCIOL, but you can see a dimpling which is shown by an arrow. It is here that you can make out that it is actually not a PCIOL, but the iris claw lens that has been implanted. And this is where the iris has been clawed to. This technique is a very simple technique. If you are apt in tackling your own PCR, if you don't create more complications when you land up in a complication, then you can very well go ahead and learn this technique, which is a very simple technique. It gives you a good visual outcome, and it is a technique that gives you reproducible results every time, because you are placing the lens where the lens is exactly supposed to be, that is in the posterior chamber. It is far away from your corneal endothelium and also away from your angle of the anterior chamber. So my journey with the iris claw lenses started in the year 2009 when I was working in Rishikesh, and I got an opportunity to visit Shankara Eye Hospital at Bangalore, where I noticed that in spite of having the flooded OTs, whenever there was any complication with the trainee, you have lots of trainee doctors out there. So they were managed so beautifully with no extra time. It's just the amount of time that you require to implant a PCIOL. They implanted this iris claw lenses. So I took this opportunity to see the post-op cases the next day, and they were doing tremendously well and with a good visual acuity, crystal clear corneas. But yes, I got to observe just 2 cases of iris claw lens being implanted. So back home, I was impressed, no doubt, but there was lots of questions that bombarded my head. Is this lens going to stay? What if there is iris atrophy and the lens drops down? And since we are enclaving it to the iris, will it be a cause of uveitis? Will CME occur? Will the patient have visual disturbance? And so I tried to find out the data regarding the long-term results. But I am talking about 2009. At that moment, we didn't have any long-term study results that was available regarding the retrofixated iris claw lenses. But today, yes, we have the long-term results which suggest that iris claw lenses are also a very good alternative when you don't have the capsular support, and the results are equivalent to the SF IOLs. So like any other surgery, definitely there is a learning curve. And this is a technique which you don't get to learn every day. You don't have a training session because you might land up in such a case once in a month, or maybe it is once in 9 months, once in a year, or once in 2 years. So you have to learn for the technique from each and every case that you are doing. So for this, you need to have a good mentor with whom you can discuss the problems. You have wonderful videos on YouTube. We have Dr. Megur's beautiful videos on iris claw lenses. But there are some missing nuances and links in these edited videos. I suggest that if you get to see the first iris claw that was implanted by the surgeon, only then you understand what the actual problems are when you're holding the lens and when you are placing it retropupillary position. Not much instrumentation is required. You just need to have your lenses and you need to have these forceps, the iris claw lens holding forceps. So you need to learn from, as I have mentioned, from every case. If you are planning for a secondary IOL implantation, then you have the time to order your lenses. But if you are planning to do it on a regular basis, you need to have your entire gallery of lenses so that you have the IOL power which is required at that very moment. So you have to know your strengths and weaknesses, and you have to be confident to manage such cases. There are certain cases, of course, you cannot use it in all the phakic cases. You have larger iris defects, you have unregulated glaucoma, you have gross uveitis patients. Avoid iris claw implantation in such cases. So as I have mentioned, whether you go for a primary implantation or secondary implantation, you can go for the AC implantation or retropupillary implantation. I don't do the anterior chamber implantation, but for the retropupillary implantation, you have an A constant of 117. And the optic size is 5.5 millimeters. So this is the minimal amount of incision that you need to have for implanting the lens. Now, before I proceed to the actual videos, what are the extra things that we have to remember when we are starting the iris claw lenses? The entry can be either your serial entry or you can go for even a clear corneal entry. The entry has to be minimum the size of the optic, which is your 5.5 millimeter. You need 2 additional paracentesis, which is 180 degree apart. And preferably these paracentesis should be short paracentesis and preferably limbal. Why? Because this makes your instrumentation easier. And also you don't get the ovalization of the pupil when you are doing a short paracentesis. In a long paracentesis, you tend to have ovalization. And you have to master a good vitrectomy. You have to get a constricted pupil by using pilocarpine. Because if your pupil is not constricting on table, then it's better that you just do a good vitrectomy and postpone the case to an alternative date when you can go for an iris claw lens implantation, a secondary implantation. Or if you are not of this opinion, then you can go for even an SFIOL, refer it to your VR surgeon. So the floating lens which I have shown in my previous video. So in this case, I prefer doing an SICS because here after making the incision, after entering the AC, you see the entire nucleus has already come into the AC. So not much to be done. You just need to take out this nucleus from the anterior chamber. So once this is done, now what do? You need to do a good vitrectomy. You need to inject pilocarpine. The 2 side ports are already made. We take the iris claw forceps, hold it with a MAC forceps, introduce it vertically. Educate use of viscoelastics are very important in these cases to avoid the endothelial touch. Then slowly with the help of a dialer, you can slowly and smoothly rotate it to the horizontal position, the position where you have made the side ports or the paracentesis. Then you hold it, and when we hold the optic, we see that we hold it exactly in the center of the optic, glide the haptic beneath the IOL, and just hinge it with the help of a dialer, or you can take any other flat instrument. We have to remember that when we are holding the slight fringes that we see in the forceps, it is an indication where actually we will find the haptic holes, because initially when we are using these lenses, we are confused that where the haptic holes are actually lying. So you just need to lift the lens a little bit, and you know those two pointers which are there in the forceps will tell you the exact position where you have to give the below nick to enclave it the iris. A case like this, where there was an old ACIOL that was implanted and the cornea was in a very bad state. So here also our option was the iris flaw lenses. Here again the side port is done. As you see, the cornea is already, it has started showing the signs of decompensation. So we need to take out this ACIOL first. So the lens is slowly taken out, and now again you have your own choice whatever you plan to do in such a case, but most preferably if you can do a good vitrectomy, if you can get a constricted pupil, you can go ahead with the iris flaw lens implantation. Just place it centrally, a firm grip on the optic, and then a slight nick, and here you can see the dimpling in the iris, and you are sure that your claws has been unclaved. And you can repeat your vitrectomy after this, and your job is done. Similarly, some untoward complications may occur in a OT. You are in a normal OT, you are doing a normal case, then also some complications might occur. And this is also another point where your iris flaw lenses are come handy instead of just leaving the patient faking. I'll just skip this because here, yes, you see there was a back pull, so you have to manage this case, and a vitrectomy was done. And once the pupil is constricted, we can go ahead with the iris flaw lens implantation as explained. Sometimes when you are provided with a secondary case which has been done by another surgeon who has given you a platter where a very good vitrectomy has been done, the pupil is constricted, this cases becomes easier for us. You just need to implant the IOL, rotate it to the position, glide it beneath the optics, and just enclave it the iris. So I'll just skip this because it's exactly the same procedure. So the advantages definitely are that you have a minimal learning curve, you have minimal instruments that is required, and it's definitely a faster procedure. And for the patient, you have a safe cornea, you have a safe anterior chamber angle. Complications do occur, and disenclavation of one side may occur initially. You may have discentered IOL, and ovalization of pupil is very common, but it doesn't cause much of a problem. The corneal endothelial cell loss is comparable to any other phaco cases that we are normally doing. So the important tips of starting an iris flaw lenses is that you need to have a good vitrectomy. You need a small central and round pupil. If your pupil is not constricting, just do a vitrectomy, leave the case, let the cornea settle, let the vitreous settle, and then go ahead with the secondary implantation. Do a short paracentesis, preferably a limbal, to avoid the ovalization of the pupil. The tip of the forceps should not cross the center of the optic, because the tip of the forceps and where you have the haptic holes, they are aligned in a straight line. So when you hold it exactly at the center, you know where your haptic hole is going to lie. And don't leave the optic unless you are confident, and until and unless you see the dimpling in the iris. So post-operative management is like your usual cases. There may be transient IOP rise initially, for which you can give your anti-glaucoma medications. Dilatation is not at all an issue in iris claw lens implantation. You have a good dilatation. Even if the patient requires some retinal management later, dilatation is sufficient enough for those cases. So this is the picture of a retropupillary iris claw lens that has been implanted, and definitely it has the advantages of a through posterior chamber implantation with a low intraoperative and postoperative risk. Definitely, it eases your effort, it reduces your instrumentation cost, and saves your time. Thank you so much.
Thank you, Jayashree, for the extensive discussion. Excellent demonstration of how to hold the IOL. I think that's one thing that addresses the most gray area when somebody wishes to start iris claw. Shishir, I think it makes sense to take up the next talk next so that we can discuss both of them together because they're related. The next talk is on SFIOLs, and in comes Dr. Sneha Jain, who is a prolific cataract and vitreoretinal surgeon who did her MBBS and MS ophthalmology, both from the state of West Bengal, and is practicing at multiple private institutions, both in the capacity of cataract and vitreoretina specialties. Dr. Sneha, you there? Did she think that...
Hello, sir. I'm just having some problem with my connection. Can you just give me 2 minutes? You can just take up, I think, a few questions, and then I can just join.
Sure.
Yeah.
All right. So, as I said, the first and foremost tip that I wanted to come out of your presentation is something that you highlighted beautifully in the end. Where should you hold the IOL so that the break in the haptics or the defect in the haptics or the discontinuity of the haptics, despite of it not being seen, is something that you can gauge very well. There's one small caveat. I mean, this has come from one of my patients, since you mentioned contraindications and a few of them. I had a patient who was complaining consistently of one where retrofixation had been done elsewhere, and he was complaining of a very strange oscillopsia. Very interesting case, very strange oscillopsia. He was complaining of the image moving here and there. I checked the patient, I found nothing wrong. Then I found out that it was a vitrectomized eye, wherein the iris fixated dial was placed, and there was a lot of tremulousness of the iris, which was actually causing the whole lens to move. So that should be put in. In fact, I put it in as one of the relative contraindications, if not absolute, one of the relative contraindications. If you have a vitrectomized eye and the iris is very tremulous, along with the iris, what also flutters is the IOL, and the patient might just complain of the image does appear shaky then. All right, bringing in Dr. Ashok Nanda is here.
Actually, can I reply to this?
Please.
Actually, the point which you have mentioned, it is a valid point, and it has actually been mentioned because some amount of pseudophacodermosis, it is very inherent to the procedure itself. You tend to have a slight movement. Yes, definitely, if it is a vitrectomized eye, I haven't done it in a totally vitrectomized eye. In a vitrectomized eye, the amount of pseudophacodermosis that is occurring, which is inherent to the procedure, it will be aggravated. So that can be a good take-home message that yes, in a completely vitrectomized eye, the patient might complain of these oscillations. Thank you.
Dr. Ashok Nanda, you there? Dr. Amit, Dr. Rajesh?
I am there, Anurag.
Hello, sir.
A little busy with conference work, but otherwise I'm there.
No, I wanted to ask you if you're busy with the conference work, did you get to hear the presentation at all?
Partly, yes.
Do you have
partly.
any? Yeah.
Yeah, tell me what all you want me to discuss out, because see, frankly, iris fixated lenses is something which I have tried a couple of times and I have not been very successful in that. The main reason I felt was probably how do you hold the lens. The most important point is stability of the lens. Once you have the lens stable, probably you can notch the iris into it. Otherwise, it's very difficult holding it with a limbs or any other McPherson forceps doesn't work.
Very true. So that's the reason why you have a broad-based forceps, which is typically used
you
to
need
hold
to
the...
take the iris fixated forceps for
Absolutely. It doesn't
McPherson only for introducing it, but not for fixating.
Sneha, you ready?
Yes, sir. Thank you so much
Okay,
for the
so
kind introduction and also for getting in
but we
some
can't see
questions.
a thing on the screen, Sneha. Just a moment.
Yeah, because
Will it come?
yes,
Is it animated?
it'll just come in. Yeah. So
Okay.
I'm sure no one likes to keep the patient's aphakic, especially after a case of surgical aphakia. So one option to salvage the situation where the capsular bag is lost is the iris claw, which has been very beautifully explained by Dr. Jayashree ma'am. The other option is SFIL, especially useful when the iris tissue is either damaged or it is absent. So a very good evening to all. I'm Dr. Sneha Jain, and today I will be discussing on the tips and tricks to perform SFIL. So there are multiple techniques to do the SFIL, both sutured as well as sutureless, with multiple variations, but the basic principle remains the same. So it is to avoid the lens tilt. The point of fixation should be equidistant from the limbus. The lens should be placed in the sulcus and the haptics to be fixed exactly 180 degrees apart, centered on the cornea. So there are certain prerequisites. One is to maintain the tone of the eye during the procedure. Either it can be done by using a posterior chamber maintainer, which is inserted 3.5 millimeters from the limbus, or a AC maintainer. I would like to highlight that you can use also a trocar as an AC maintainer just by inserting it 1.5 millimeters from the limbus in a valvular fashion. So another important prerequisite is a good vitrectomy with indentation and vitreous-based shaving. This is to prevent the post-op complications like retinal detachment. The vitreous tags in the anterior chamber should be identified either by using tricot or by sweeping your instrument like a Sinski or vitrectomy cutter in the anterior chamber, and it should be removed meticulously. So the sutured IOLs with 4-point fixation using polypropylene or Gore-Tex is an old technique and which is very beginner friendly. And since this is about how to start in your practice, I will be starting with this. So the basic steps are of this procedure will be dealt now. Flap creation. The flap has to be exactly 180 degrees apart. Either 3 or 9 o'clock or a 2 or 8 o'clock position is good. And very important to have an adequate thickness of the flap, around 2/3 of the scleral thickness, so that to prevent the exposure of knots, especially with thick sutures or Gore-Tex. I prefer a 3x2 or a 3x3 millimeter flap. And also important is the size of the sclerocorneal tunnel. When using these rigid IOLs, it should be adequate around 6.5 to facilitate the manipulation of the rigid IOL. While using the polypropylene needle suture, the needle goes into the eye through the distal part of the flap. This is what I follow so that it becomes easy. So it goes in through the distal part, comes out through the proximal part to form the loop. So distal part of the flap, 2 millimeters from the limbus, ensuring that it goes behind the iris. So it has to be a more perpendicular entry. For exteriorizing the needle, a 26 gauge needle is used, and it is advisable to bend the needle around 90 degrees, very close to the hub, so that you get a bigger or a longer length to manipulate it. Also, a very important tip is whenever any sharp needle is entering into the eye through the sclerocorneal tunnel, then you have to use a second instrument just to lift the tunnel so that there is no tissue incarceration. So next in the step is docking of this needle, of the straight needle, and removing it out of the sclerocorneal tunnel, after which it is passed through the eyelet of the SFIOL. Now, another tip here will be basically to hold the optic and never the haptic. Haptics are a bit fragile, it can snap. So the loop is then completed by bringing the suture through the proximal part of the flap with the help of a 26 gauge needle. The distance between the entry side, which is here, and the exit side should be at least a millimeter so that you get some place, like you can put the suture and there's some hold over the sclera. So once that is done, we do the same thing on the other side. A small clip just to show that there should not be any mixing of the threads. So here we can see that the thread of the right side is all pulled to one side. And when you're inserting or removing the thread for the other side, you make sure that you don't go through the in between the threads of the other side. So by pulling it before entering into the anterior chamber. So before inserting the IOL, some visco can be injected into the into the chamber so as to protect the endothelium. While inserting, the leading haptic goes in first, while applying gentle pressure on or gentle pull on the sutures on the left side. Then comes the trailing haptic. Also, another tip that I follow is basically to use a Sinskey or a dialer and place it on the optic so as to prevent the optic from inverting or turning in the posterior chamber. So it helps in for the IOL to not rotate in the posterior chamber. So once that is done and both the sides are tugged so as to get a perfectly centered IOL. So after this, the knots are placed. The knots are done on one on either side, and the centration is checked before going in for the rest of the 6 knots which are placed. So in total, 7 knots on each side. So this is a lengthy procedure. So so many knots being tied. So excessive pull on the suture should also be prevented because it can lead to the suture it can snap, especially when you're using a 10-0 or a 9-0 polypropylene. So next is to cut the sutures cut the suture very close to the knot so that it doesn't come out through the scleral flap. It is important to get a watertight closure of the sclerocorneal incision. The flap, if they're very thin, they should also be sutured. Otherwise, the conjunctiva can be closed with either a 7-0 vicryl or the use of a fibrin glue. Now, coming to the sutureless techniques, there are many, the popular ones being Yamane, but it requires special handheld instruments like the handheld cautery. Now, what I use is the intrascleral fixation of the haptics into the Gabber's tunnel. And for exteriorization of the haptics, this technique with foldable 3-piece IOL can be tried, where all the manipulations are done inside the eye. Getting the leading haptic out is fairly simple, but getting the trailing haptic out of the eye requires mastering the handshake technique and can lead to a deformation of the haptic with multiple attempts. So a solution to this is the XNICT, which is the extraocular needle guided haptic insertion technique. Here, a 26 gauge needle is pierced 2 millimeters from the limbus, guided from behind the iris out of the tunnel to dock or thread the haptic of the IOL into the needle. And with one smooth movement, the haptic is exteriorized and held by its tip by the assistant. Now the same is repeated on the other side. A tip to follow while threading the trailing haptic is to keep the needle at the far right corner of the tunnel and to hold the haptic very close to the tip so as to prevent any excessive damage to the haptic. While exteriorizing the haptic also, hold it with a McPherson before withdrawing the needle to prevent excessive pull at the optic haptic junction. So once they are out, it is fed into the tunnel. Here also gentle manipulation should be done. Otherwise, it can lead to deformation of the haptic as in this case. So so here it's showing how we are feeding the haptic, how the haptics are being fed into the Gabber's tunnel. It can be adjusted to ensure the centration of the IOL. So now coming to how to construct the Gabber's tunnel. Now they are basically made after localized peritomy using either 26 gauge needle or better what I prefer is a 23 gauge trocar. It gives a very snug fit for the haptic. 180 degrees apart, 2 millimeters from the limbus, starting a millimeter away from the point of exteriorization of the haptic. And they're running almost parallel to the limbus, tapering towards the end so that it follows the natural curvature of the haptic. And length of around 4 millimeters is sufficient. The right side will point towards away from the surgeon and the left one will point towards the surgeon. So A small trick that I use to tackle the problem in localizing the scleral pockets, because they have to be made before doing all the manipulations of exteriorizing the haptics, is that to mark them with a blunt cannula stained with ink or of the tissue marking pen, or just to inject some trypan glue into it. Also, to decrease the dependency on the assistants, helpful to use a stopper for the leading haptic, which is made out of a small silicon piece, which is cut out of a 240 band. And it is mounted on the 26 gauge needle before introducing it into the eye. And when after docking and while removing the haptic, it is just slided from the needle onto the haptic before withdrawing the needle. So another technique which is very popular is using the CMT Flex IOLs. It is fairly easy, and which has a T-shaped haptic that is pulled out through a 23 gauge sclerotomy under the scleral flaps to suspend the IOL. Now this video is courtesy Dr. Vikramjit Pal, and it's beautifully shown the procedure. Important, you can see the site of the incision here. It is almost, it has to be 180 degree from the site of exteriorization of the first haptic. And the important part or tip is to where the haptic is held. It is held at the stem of the T-shape of held at the stem of the T-shape, and it grasps really well before pulling it out. So I would like to end by saying that there are multiple techniques to do scleral fixated IOLs, and the best ones are the ones you are most comfortable with. So you can start with sutured, go on to the X neck, or you can just go on with the CMT flex technique. I would like to also thank Dr. Devashish Das and Dr. Devmallo Das for this opportunity to present in front of you all and to be a part of this webinar. Thank you.
I think you did your best to make it look like a debate between you and Jayashree, which technique is better. And that's from where we begin the post-presentation discussion. I would like to involve the three invited faculty first. Is it universally agreeable? A question to all three of you, and I want short and crisp answers. Is it universally agreeable that the posterior fixation of iris flow IOLs behave, function as well as the scleral fixated IOLs? Deepak bhai.
Yeah, I think the answer to it is how well these techniques are done. A bad surgery with either the technique would be bad. Okay, so the debate is not about which technique, how well you can do it. Okay, the most common question or misconception people have is that iris claw seems to be very easy and I can do it. Okay, the problem is most complications happen because they don't do a good anti-vitrectomy. So don't blame the lenses for it. Okay, you have to do a very neat job. Either you're doing a scleral fixated or a thing, you deal with the vitreous appropriately. On the same time, if I say no, trying to do an mRNA or doing something, and you don't know the anatomy of the pars plana appropriately, and you create a very big catastrophic complication, just like how Abhishek was telling you. So I think you should be good at the technique rather than blaming at any of these lenses. So the first thing is always learn to do a good anti-vitrectomy. And if you can do good anti-vitrectomy, most things can be done well. Obviously, one point which is against or which is sometime against the iris flow lens is the increased pseudophecodinosis. That is the one thing which is the only thing which is slightly off. Otherwise, the complication rates are maybe slightly different from each other, but they're unique. Both of them can get dislocated over a period of time, and both can have CMEs. And in fact, the scleral fixated can have lens tilts and cause more astigmatism. So nothing is perfect if not done very well. So ultimately, the bottom line is it depends on the surgeon, how well has he understood the concept, and then that's it. And you know what, the Yamane and other things, they are also at risk of causing endophthalmitis, which we don't discuss much. But nothing is foolproof. Once the time passes on, you'll all come to know like what pitfalls we could have had with any of these things.
Arup sir, your take on this?
Yeah, I think both the presentations were very elegant and very nice. So Anurag, you have left out one lens, anterior chamber lens. See, I don't think any individual that I know of has adequate experience with the numbers, with each technique, which type of lens, to say that in my hands, this is a statistically significant superiority of this particular technique over the other techniques. So I would just tell you that there have been a lot of meta-analysis that have been coming up in the literature every second year, third year, the preferred practice pattern, and you go to various meta-analysis. There's no difference. So here, what Deepak had mentioned, that if you follow a particular technique properly, whether it is an anterior chamber lens or whether it is an iris fixated lens or a scleral fixated lens, if you know how to do it properly, if you have gotten yourself properly trained and good experience, I think you should be able to get good results in whatever techniques which you feel is most suitable for that particular patient. I have been doing a lot of anterior chamber lenses, not lot of the anterior chamber lenses, but I have done lots. If I take my career into account, starting from the Arvind days, so most of the bad results of AC lenses were not because of the AC lens design. It was because of badly done surgery and then badly managed complication. Same thing can happen with the scleral fixated lens, iris fixated lens. So basically, the surgery has to be very gently done. The complication has to be managed exactly in a copybook manner, and then use the lens which you feel is best suited in that case. Now, in my scenario, if I get an aphakic patient, so refer to me for further management, where a surgeon has already tried to remove the nucleus, through the scleral tunnel, phaco converted to SSCS, or SSCS where there's no adequate support. So already a tunnel is there. So in that case, I would be using a rigid scleral fixated lens with an eyelet with 7 Gore-Tex suture. This we have developed a lot of experience over the last maybe 6-7 years, and they have done. You should know how to handle the Gore-Tex. Is not easy to handle. You have to learn it, but believe it or not, very good fixation happens. Now, if it is a small incision, like let's say in a 2.8 millimeter clear contact incision, nucleus has dislocated, the lens has dislocated, and then depending upon what type of lens. So if it is a 3-piece foldable hydrophobic acrylic lens that has got dislocated, then I would be using the Gaber-Shariat's technique, what we call as a glue dial technique, because you don't really have to enlarge the incision, and then it is quite easy to accomplish. I have not built up that much of experience with the Yamane technique because I don't deal with so much of it's not a teaching institute where you have a lot of aphakic patients, aphakic conditions that fit onto your table. So I have done a few Yamana's technique, but I feel that there's a lot of learning that is involved. It is evolving. Recently at the ESCRS meeting, there was a course of Yamana that I attended. He just currently is using a technique which is very different from what he had initially described. So it is an evolving technique. So I would say that if it is a large, already big incision to start with, scleral fixated lens, rigid lens, 6.57 millimeter optic, Gore-Tex fixation. And if it is a small incision case to start with, then the 3-piece hydrophobic acrylic lens with intrascleral haptic fixation.
So done well, both of the techniques, both the lenses work very well, work optimally and work equivocally. Is there anybody in the board who would like to disagree or serve a different opinion? The vitreoretinal surgeons on board in particular, all 4 of them. Dr. Lalit, would you agree or would you disagree?
I absolutely agree with his statement. Neither the research and neither in my experience, I feel that either AC IOL is either superior or inferior to any other IOLs. Strongly agree.
May I invite the other panelists to chip in with their opinions if they have any? Sujay sir, Dr. Anand Dev, Pranab sir.
Even in meticulously done techniques, the 2 different techniques can have subtle functional implications. The scleral fixated IOL can be more stable in few cases, but in most of the cases they do work very well and they are comparable.
Can I ask few questions? I have few doubts.
Yes.
So, in a cases of pediatric aphakia, what would you prefer? Because scleral fixated become very dicey in pediatric aphakia because they tend to grow and you have chances of, I'm talking about glued sapphire. So
The standard sutures that we use are also a concern, as Arup sir was mentioning. If it has to be fixed to the sclera in the pediatric age group, it has to be fixed with Gore-Tex. You cannot use a 9-0 proline there because it'll erode, certainly, and it's almost invariable for the IOL to get dislocated. What I would do, and what I have been doing in my practice of PDOF, is that in the pediatric age group, strictly, I do not revert to the IOL for correcting aphakia. I would take different measures which are other than IOLs to correct the aphakia, prevent the amblyopia, let the child grow, let him attain an age wherein you can do it more atraumatically, and then possibly do some secondary implantation technique. The only caveat here is the traumatic cataracts. A lot of pediatric patients come in with a traumatic cataract, and there the iris, the pupil, they all are so distorted that you cannot even think of an iris fixated IOL there. So they're very distorted. So if it's a traumatic aphakia, then the scleral fixated IOL becomes the only choice.
Scores over iris fixated.
Over iris fixated, yes. Over iris fixated. But yeah, I mean, that should be done after the globe has attained certain degree of maturity, where you're not expecting it to grow and cause a myopic drift over a period of time. And you're also sure that you're fixating it properly so that it doesn't get dislocated with time. Because no suture, in the proline group, at least, no gauge of suture can outlive the age of the patient. It is bound to degrade before the patient ages.
In SFIL, would we agree that we would go for a, three-piece, multi-piece exteriorization of the haptic over sutured SFIL in the let's say 12 to 18 age year group?
Yeah, I'll let someone else answer that. Deepak bhai?
Over sutured SFIL?
Well, in this, see, even those techniques are we don't know how they're going to behave over a period of time in a growing eye. The eye is going to grow and the sclera is going to be stretched from anywhere between 8 to 18 years. So in that, we really don't know. We have done very few cases for us to really comment on what is going to happen there. Rest, but still, in this age group, between 8 to maybe 16, 8 to 18, my still, preferred lens is the iris fixated lens as of now. If at all the support is available as we get in traumatic cataracts, and that's a challenge, we do agree. But theoretically speaking, it looks like maybe the PMMA haptics of the multi-piece lenses, they may outlive your proline sutures, theoretically speaking. That looks to be a better option for your answer.
I have limited experience with this.
There's one tip which I would like to share. CMT Flex, which is by the Apphaswamy. I have implanted one. The implantation is much easier compared to the other scleral fixated lenses. The procedure is simple. And since you are not using any suture or anything else, the longevity is going to be not an issue. So that is one point I would like to highlight.
See, sir, it is not only the ease of insertion. When we evaluate a lens and its suitability in a particular patient age group and other comorbidities, it is the long-term stability. So my suspicion with this particular lens is, such a big thing, it is being buried into the sclera, and how the sclera is going to react in due course of time. So it is easier. It is much faster, and it looks much easier to do. But how is it going to behave? So for that matter, when a patient asks us, before any, how long the IOL will stay, we say it is going to stay lifelong. But then we have now been seeing cases of dead bag syndrome, and for no rhyme or reason, the lenses, the bag is rupturing, the lens is getting dislocated. So we really do not know. What is there in the in store for this particular lenses. So it is always better, to go look into the meta-analysis, have some discussions with the peer group, and find out what has been the longest experience, and whatever is, I think, what's best in your hands.
So I asked the same question to Dr. Manisha from Shroff Eye Hospital, and she has a very long experience of doing CMT Flex, and she was quite happy with the CMT Flex because of very good centration. And one thing that you notice with SFIL is that sometimes you get, specks of deposits on the optic if you have noticed on IOL, if you are using SFIL, and I don't know how they tend to come only on SFIL and not on iris fixator. I have not seen on iris fixator, and they say the optics was pristine in all the CMT flex, but that was of a limited experience, as you have said, sir. We require a more longer experience with CMT flex. Can I
Absolutely, because it's a very flexible material. It's a hydrophilic material. It's a very, very flexible haptic. It's short in length too. So you are going in with an MVR, externalizing the haptic, as sir is rightly mentioning. Perhaps we have to look at it for a very, very long time before we can ascertain that it's actually remaining stable inside the eye. Anand sir, anything?
No, I have no experience with iris claw lens and scleral fixated. I have stopped quite a long back.
So how do you treat your aphakic cases, or you do not have aphakic cases at all?
Actually, for aphakic cases, usually I don't have aphakic. If ever I have one, I refer it to a VR surgeon to do it more efficiently.
He does an ACIL or he does something else?
SFIL.
SFIL.
So
yeah, another point I wanted to mention, like when the first talk was getting over, it is not a crime not to keep the patient aphakic. Like if you have a PC, then the whole nucleus has gone behind. It is not necessary that you have to put a lens and then refer the patient out to the VR surgeon, because sometimes the VR surgeon may not be very comfortable in taking the whole lens out through the pass panel. And if there's a lens already in place, the intraoperative tissue handling manipulations, they become more complex, they make it prolonged, it becomes quite messy.
Sir, why I told that thing was because sometimes I feel.
No, your case was a soft cataract. I mean, see, the one that he showed, was soft cataract. So that is not an issue. But I'm talking about if you're dealing with really hard cataracts. Today, actually, I mean, I'm quite surprised that very, very hard nucleus also can be, the fragmotome can really consume them, which was not there earlier on. But still, one need to have a dialogue with the VR surgeon and find out whether he or she is comfortable with, with the task of taking the nucleus out through the pass panel when there is already a lens in situ.
Sir, and that
May I say something?
Yeah, please.
Yes. If whole of the nucleus has been come out and proper cleaning of the vitreous and as well as cortex has been done, why not primary implantation of ACIL? It is equally good. Why to send patient and again call after 1 month?
Dr. Amit Raj, we are not talking about a case that you're saying the small fragment has gone down. We are talking about a huge chunk of nucleus
Sir,
has gone down during early phaco. PCD has happened. Big piece has gone out. So what you have said is it is common sense. Why you want to postpone the IOL implantation? You can definitely 100% do it. I'm talking about more complex cases.
They call for secondary IOL implantation for either glued IOL or iris flow lenses or scleral fixated. So my take is basically when there is clear vitreous has been cleared, nothing is there, always go for primary implantation of ACIL.
In case of a dropped nucleus,
if you are a VR surgeon, you can finish in the same sitting. I'm talking about a situation where there's only one anti-segment surgeon, and he does not know how to do a pass panel lens fragmentation, and it is a hard nucleus. I'm talking about a situation like that.
Even if it's a hard nucleus, sir, in case of a dropped nucleus,
that's what I've been telling. It's a hard nucleus.
Most of the time, still a VR surgeon will always remove it by a phaco-fragmentome through the pass panel route. So implanting an IOL in the first sitting by the anterior segment surgeon, 99% of the times would not change the surgical steps that a VR surgeon would do. Even for a very hard nucleus, the fragmentome works very well. And for an experienced VR surgeon, doing a phaco-fragmentome in the vitreous cavity might actually be slightly easier compared to doing a phacoemulsification of a very hard nucleus in the small anterior chamber. If the vitrectomy is very well and completely done, we get a lot of space in the vitreous to emulsify the hardest of the nucleus as well, most of the times without causing any damage to the retina and not a very difficult situation compared to many other more trickier situations in a VR surgery. So most of the times, I think a VR surgeon would not be uncomfortable with the IOL placed in sulcus if the situation started. I would also want my anterior colleagues to place the IOL in case of a drop nucleus.
Plenty of snippets there for all of us to learn from. We have talked about the IOLs which are to be used in situations that are dire. Shishir, I want you to invite the last speaker of the evening who would talk to us about premiums, and none better than him in this board to talk about premiums to the audience. Shishir, up to you.
Thank you, sir. I would like to invite Dr. Subhash Prasad, sir, talking about premium. He is the most premium cataract surgeon of Bihar. I would not have any doubts in calling sir so. Sir is the director and chief consultant of Dividrishti Eye Center, and sir will be having this talk on premium IOLs in the setting of an impending or an established PCR. Over to you, Subhash, sir.
Good evening, everyone. Thank you, Ajok, for giving me this opportunity. Is my slide visible? Hello?
Your slides are visible.
Yes, yes,
Yeah.
visible.
So now we have come to an era where the patient's profile has rapidly been changing, and most of the patients now, they want something which can address their near vision also, and they want to get rid of a very any distance vision also. So the place of premium IOL has rapidly increased over a period of time. And so all actually nowadays implanting these lenses. This has already been dealt by Dr. Abhishek Anand, so I won't waste so much of time, but just to say that posterior capsule rupture can happen to anyone, any big surgeon can have. This is one of the most dreaded complications of cataract surgery. And whenever we plan any premium lenses, we have to see the predisposing factors which can actually jeopardize our aim of giving the patient the best possible premium lenses. So those patients must be consulted before surgery, that even if you want these premium lenses, sometimes we actually about the procedure of putting the premium lens, and you can implant some other lenses also, like posterior polar cataract, any traumatic cataract with some posterior capsule tear, or patient having undergone vitreous procedure with lens touch, or traumatic cataract. Nowadays we see not very rare to see these cases of traumatic cataract occurring after intravitreal injections. And not to mention that all these risk factors of the cases which can actually land up into the PCTA. So I won't go into that much detail, just straight away move to that. But one thing is very important, that one should respect the vitreous whenever we encounter any PCR. We must take good care of the things. And like Dr. Abhishek has rightly pointed out, that whenever you encounter any PCT, just don't get out of the chamber without infusing your viscoelastic through the side port, just to temporarily plug the PCT so that it doesn't increase or does not create much more problem. So this is the common scenario what he used to have. This was a case of post intravitreal injections, patient developed traumatic cataract. This is just to show that in most of the time, if you are not actually planning for premium lenses, for monofocal lens, if you encounter this problem, you can go ahead with the simple multi-piece lenses in the sulcus with anterior optic capture. What we have been discussing about the vitrectomy through the anterior route, limbal route, or the pars plana route, again the matter of convenience. So here also I am implanting the multi-piece lens in the sulcus, and then checking any strands of vitreous. That is very, very important. So this is one of the most common scenario, the putting 3-piece lens in the sulcus and then capturing the optic of the lens with the anterior capsule rim. But the problem is that all these premium lenses nowadays, whatever we have, all are coming in the single piece platform. So for this PCR, if you are able to consult the patient about the not putting any premium IOL, then this is the best option of putting 3-piece foldable IOL in the sulcus, then the anterior optic capture. But if the patient have been consulted or patient is planning for correction of the astigmatism through the toric IOLs, or if the patient is going for or actually willing for the presbyopia correcting lenses, and more so if the other eye of the patient has been operated with this type of lenses, then these are the situations where we must try hard before succumbing to this PCT and then resorting to these 3-piece lenses in the sulcus and then capturing it. So there is no current toric IOL options or presbyopia correcting lenses in multi-piece platform, and we all know that the single-piece lenses are not made for sulcus; they are made for the back. So in any situation, it should better be avoided not putting in the sulcus and then capturing the anterior capsule, because it may cause a lot of the UGA syndrome. So once we encounter any PCR, assess how large the posterior capsule tear is. That will actually decide whether we can safely implant the premium lens in the back, or we have to resort to some other means like the reverse capture. And best case scenario would be this small rent in the posterior capsule without any vitreous loss. In those situations, we can safely place a one-piece, single-piece lens in the capsular bag. And if there is large radial posterior capsular tear or anterior capsule tear that extended posteriorly, the options may sometimes become limited. If particularly if the anterior capsule is also has anterior capsule runoff is also there, then the options are very limited. Just I discussed. One has to see that if the PCR has occurred after placement of a one-piece IOL in the capsular bag and the posterior rent or tear is stable, one can just go ahead with single-piece premium IOL without any change in the planning. And if the PCR is not stable or large, reverse optic capture is one of the options that I will show in this coming video. That actually gives a very good support to the IOL in these situations, like putting the lens, the haptic of the lens in the bag, and then capturing the optic of the lens, bringing it to anterior over the anterior capsule. And that gives very much good support and stability to the lens. So a reverse optic capture is a surgical technique for implanting an intraocular lens that involves placing the optic in front of the anterior capsule opening. And this lens is placed in the bag and it is cantilevered forward so that the optic is in the sulcus and the haptic remains in the bag, and the rim of the anterior capsule captures it. So it is very essential to have a very good, very sufficient anterior capsule. Like if it is too big, then there will be a problem. So it should be ideally 5 millimeter or so. And care should be taken that once you have done that, ensure that the lens is stable, particularly in the toric lenses. Otherwise, the whole the benefit of the toric will be gone. So if there is any concern in the stability, even though you have committed something, even if the patient has something better in the other eye, one has no other option but to go with the 3-piece lenses in the sulcus. And it is always, as said earlier, it is always better not to do single piece IOL in the ciliary sulcus. So this is one case of traumatic cataract pre-existing PC tear. Patient had trauma and you can see a big tear there. You know that this patient might end up in the problem, but this patient had significant amount of astigmatism also. So I tried, and since the nucleus was very soft, so I went ahead to perform this surgery of putting the toric lens in this patient, as the patient's astigmatism was quite high. So here just by manual irrigation aspiration helped, and at no point of time in this situation let the chamber collapse. So always take extra caution that you inflate the chamber before coming out, and then changing the hand, and then removing the cortex from the other side, keeping the parameter in the very safely, and just taking out every bit of the cortex. It's not a problem. As you can see that still the anterior highlight face is intact. Now plugging the PCT with the chondroitin sulfase and then putting the lens in this situation. This is a toric lens, putting in the bag, and then since you can see that the axis of the PCT was nearly along the axis of the placement of the toric lenses, but still it was possible to do gentle maneuver and then place the lens in the axis of the desired placement without causing any disturbance to the anterior highlight face or any disturbance to the vitreous. So a very good result can be achieved. And even see here, I'm using this cotton, this swab stick just to plug the other side port so that the fluid doesn't come, so the acid doesn't collapse. This is the situation of the posterior polar cataract. We all know that sometimes we encounter PCT here during the cortical expression. Actually there was blowing out of the posterior capsule, and then it extended in a radial manner. Yet it was possible to accomplish complete removal of the cortex. View is not complete because of some decentration of the microscope. This is just to show that though this was a single piece lens without any added anything extra like trifocality or anything, but just to show that in these situations also, if you maintain the compartmentalization of the eye, you can very well place any kind of single piece lenses in this situation. Only thing is that you orient your haptics in such a manner that it is away, or it is 90 degree away from the axis of the tear. So coming to one situation of there is something wrong with the loading of the lens. You can see here. It's the lens suddenly came out like a jet and then toward the posterior capsule, but still, and this was being done under the hydroimplantation. You can see the tear here, but still maintaining the chamber adequately, it has not extended, and I'm trying to place the lens in a way that the haptic gets the maximum support all around. So I'm rotating the lens gently, and this was achieved, and the patient had very good outcome even with this little bit of problem encountered during the surgery. Coming to the another situation, if there is intraoperative PCT before putting some premium lenses, what you can do is that if there is a rent in the posterior capsule, you can make it round like anterior capsulotomy, that is a posterior capsular axis. So this was a case of trifocal lens planned in this patient, and everything went well. But again, the problem this was encountered during the irrigation aspiration. Some overconfidence, or you can say that some lack of attention actually led to that ripping of the capsule here. Sorry, you can see the big rent here. So the option is again to plug the opening in the posterior capsule, and then I did the bimanual limbal vitrectomy here just to clear any vitreous whatever there in this area or in the anterior chamber. And then using the forceps macroaxis forceps, I am trying to make it round. The posterior capsule tear, I am trying to make it round, and after having confirmed that there is adequate support about the lens to be placed in the bag, I gently, slowly putting the lens, taking utmost care that there is no sudden opening, and then with the help of Sinski, I am putting the other haptic in the bag between the posterior capsule and anterior capsule, and the lens was quite stable, and I'm just pressing the lens. You can see my left hand pressing the lens, still the lens is very stable. So I was sure that the lens is in the perfect position and this patient is not going to have any problem. Trying to take out some viscoelastic from behind the lens by through the cutter, and then checking whether there is any vitreous in the anterior chamber or not. That is very important. And then hydrating the wound before taking out the irrigation. That is very important. Not letting the chamber to collapse anytime. This is one situation where it is sometimes very tricky, but it helps in some situation. This was a patient, other eye had a toric lens implantation done few months back, and there was significant amount of astigmatism in this patient. So definitely I was actually going for the toric lens implantation. This patient T6 model was actually chosen for this particular patient, and you can see the axis of placement of the lens is the same, almost same as the axis of the incision. So the problem which I encountered was all because of this. Had it been in some other axis, then I could not have gone for this reverse optic capture. You can see that in this patient also I encountered similar kind of problem. The lens actually came out in a very jerky manner, and then it was about to sink into the posterior, into the vitreous cavity, and then I just pulled it from sinking it. And then the options available was again 3-piece IOL, placing the same lens in the sulcus with optic capture, which is not recommended. And the last one, which is I'm going to demonstrate here, is the reverse optic capture. So what I did here is that try to just stabilize the lens in the whatever bag remnant is there, and then taking the help of the iris spatula and the Sinskey hook, I am taking out the optic and trying to place it over the anterior capsular rim without causing any disturbance into the anterior chamber, and so that there is no vitreous coming into the anterior chamber. You can see that I am trying to just playing with the two instruments, bringing this up on the anterior capsule rim. And you can see here I was successful in doing that. And after this, again, I checked for the vitreous, and so this was the situation where I took help of this reverse optic capture, and the axis of the placement was almost as desired. And this was the area of rent. Had it been like somewhere here, I could have not done this. So again, maintaining the chamber throughout, and the patient actually had very good outcome. So this is the post-op picture, and the patient had very good outcome after the surgery. So just to summarize, PCTR can happen anytime by anyone in any situations. The common practice, what used to be and right now also, is multiple foldable IOL in the sulcus with optic capture. That is the safest way. And for toric correction of multifocality, which is coming only in the single piece platform, we should learn how to deal with these situations, even in these tricky situations. But one thing that is very important is that one has to take care of the chamber stability throughout and never lose your nerve. And when there is a small defect, place the lens in the back. Large defect, you can go for the reverse capture, but definitely it requires expertise and patience, and your you should be cool and should be able to manage that in a very, should be ready to spend some time also. So premium IOLs can be implanted in most cases even without sufficient PC support. So thank you very much. Thank you very much.
Thank you so much, Subhash sir. We can move to any discussions on this or the previous presentations by our panelists, Dr. Salabh sir, Dr. Rajesh Agarwal, Dr. Ashok Nanda sir, and Dr. Sujay Samanta sir, or any of our national and international faculties.
I'd like to ask you a question, Dr. Subhash. Since you showed the reverse optic capture in a case wherein it was mandatory and it was called for only after you pushed in the IOL. Say you have a situation wherein you have a PCR and you are planning to put in an IOL, which is a toric and of the trim of T6, T7. And if the other eye already has a toric, then we must do it. And the axis of implantation or axis of orientation does not allow you to keep the IOL in the back. Since the optic is placed up, you're doing a reverse optic capture and the optic is placed above the rhexis margin. Would you like to undercorrect the dioptric strength of the IOL, or would you like to push in the same IOL that was calculated initially?
As per the report, it says that it doesn't make any difference. But if you are doing a posterior capsular capture, capsulotomy capture, this was anterior optic capture. So if you are doing posterior capsular, then you have to undercorrect it by, you have to actually overcorrect by 0.5 diopter. But here it is not needed in this situation.
Deepak bhai, what's your take on this? It's a very interesting situation. This thought just crossed my mind.
See, it's a very valid point. But in crisis situations, see, ideally it would give you minus 0.5 spherical. Okay, you're pushing up the lens. It's going to give you minus 0.5 spherical.
0.5, yes.
It is going to give you minus 0.5 spherical, no doubt about it. But you have to live with that devil. So because usually we don't have a backup lens. Plus 0.5 extend, minus 0.5, we don't have. So that is the thing which you have to live with. That's the best option which we have, and you expect this to be.
I was just thinking and churning it out further in. This was a monofocal toric that Dr. Subhash showed us. If it is a trifocal.
Even if the astigmatism is very high, and if you are not able to write on the axis, And by any means, if you have to rotate it little bit, make it 5 or 10 degree. So even those situations, it will decrease the astigmatism, but may not take full care of that.
Agreed, sir. I'm talking about this. That's the reason I said, let's churn it further. Let's go deeper and think about the trifocal IOLs, wherein a myopic residual is actually less acceptable than even a hypermetropic residual. So there you have pronounced halos on the macula. So if we have a situation like this, God forbid, the other eye already has a trifocal, this eye is scheduled to receive a trifocal, and you have a situation wherein the IOL just doesn't sit properly in the back, and you have to do an optic capture, reverse optic capture. Then what do you do? I'm just thinking aloud, seeking opinions.
I think in when you're doing a multifocal lens, trifocal lens, in your catch-22 situation, either way, whether you're putting in the bag or out of the bag, I think we need to be discussing. You have to do whatever you feel right, but at the same time inform the patient that it might require a second intervention.
Right.
Patient might not be happy even if you put it in the bag after a PCR because he may develop a CME or you God knows what happens. But in this case, definitely, as you see, the point of near vision decreases still further, and that is going to be an issue. Especially, it's a lady who has got, especially as a man who has slightly longer hands. Maybe those are things which you have to consider. But any of these cases, I think you have to be ready to replace the lens. If I put it very bluntly. So you have to be ready with if you want to go ahead with the trifocal lens in such a situation, we should be mentally prepared to have a resurgery with this, and you should have so much confidence in the patient to allow you to do that.
Pranav, sir, you were saying something.
Yeah, Dr. Anurag, you do not have the right power of lens spare. What will you do? If you have it, then well and good. You go for the slightly lesser power. But if you do not have it, you have to compromise.
No, obviously, I was just talking about the ideal situation. You know,
Anurag, you got it a very valid point. You got a very valid point. Suppose if you're dealing with a complex situation like posterior polar cataract, you
particular specific trifocal for that particular patient.
Right.
You do not have the extra one. I mean, that is a catch-22 situation.
Yes, Deepak bhai.
Maintaining.
Yeah, so your point is very valid. But in those situations where you see you're expecting a problem, like a posterior polar cataract, in that case, maybe you're valid to get one extra lens, which is having lesser power compared to what you're in the bag lens. Because in the situation, you're already mentally prepared to place the lens anteriorly. So maybe you are going to have an extra backup lens, which has got slightly lesser power in this situation. If you're already doing a complex case like your posterior polar cataract or something like that. So you're already mentally prepared have a backup lens. Otherwise, what is best in that particular situation? If the other eye is not so, is not having a multifocal lens and situations and things really get complicated, I think best would be to go ahead and put on monofocal lens in such situations.
Yes, Sujyo sir, you were saying something.
Yeah, when I plan a multifocal lens, I generally have three lenses.
Proper lens, put that lens. Otherwise,
yeah, when I'm planning a multifocal, I generally keep three lenses in my stock at the same time, the same OT. One according to the ELP, one slightly on the minus side, and one slightly on the positive side, depending on which technique I use to finally fixate the lens. If I do like a capsule fixation, then I put it slightly on the minus side.
So you're saying that for each patient that has been planned or scheduled to receive a trifocal IOL, you order 3 dioptric powers, 1.5 more and 1.5 less than the calculated power.
Yeah.
Fantastic.
Like PP cataract or
that's
for situations like those. Okay, okay. Makes sense, actually. It makes sense.
Very good idea.
Anybody else? Jayashree, I mean, it's not mandatory that speakers or moderators are not panelists. You're also in the panel. You can also raise a point if it deems plausible to you. Lalit sir, would you like to offer anything as a comment?
Nothing from my side, sir.
All right. Anand sir, do I find you a little droopy, sir? No. Okay. Anand sir, what's your take? Anything else?
Actually, I have one thing which I had experienced recently only. While doing a PPC case and everything goes on fine, but while putting the IOL and before injecting the visco should be not very much, the eyeball should not be too much inflated. Otherwise, that also causes a PCR.
True.
So I had, because I implant the IOL in sodium hyaluronate 1.4%, and I was so enthusiastic. So I just put little more of visco, and then PCR was there. So that point also should be considered in cases of PPC cases. Inflating the means adequate amount of viscoelastic should be put.
Okay, just one food for thought that again just struck me very fresh. Since we are talking about putting in toric IOLs in the event of PCRs, how important is it to do a complete vitrectomy at the site where the PCR has happened? Because if you are implanting a toric to negate the pre-existing astigmatism, and you leave behind a vitreous knuckle that pushes one end of the optic up and causes an effective IOL tilt, even if it's inside the bag, then you're effectively, negating or neutralizing the advantage you were supposed to give the patient. So isn't it very mandatory that we talk about a complete vitrectomy, even if the PCR is small, particularly when we are implanting a toric IOL? Subhash sir, Deepak bhai, your take?
See, in any situation, if there is some problem, we are going to have some kind of deviation from the outcome. So I think that once you have done a good vitrectomy, you have ensured that the anterior chamber is fully formed, there is no strand, and the lens is in the perfect position. It should not have any any vitreous knuckle pushing the optic or anything behind.
I think the most common reason for lens decentration, either a multifocal lens or a toric lens, is the presence of vitreous which has been missed during the surgery. So you spend ample time in finding out, because it's very easy for us to get fooled. The vitreous is very intelligent. You think you've done a good job, and one strand somehow comes there and sneaks in. So spend a little bit more time in doing this. And if you can do a good job, actually, toric lens is no issue at all. You'll be perfectly fine. The second important point is try to do a posterior capsular rhexis somehow, if you have an opportunity, unless and until it has extended all the way equator to equator. Other than that, if you have an opportunity, once you put in do a rhexis, most likely they're not even, we can go ahead and put in a multifocal lens as well. See what happens, even if you've done a good vitrectomy, but you're not converted that loose ends into a circular end, you're trying to put in the lens, that is the time the haptic itself can stretch the tear. So don't be fooled that, because you've done a good vitrectomy, the PC tear is unlikely to enlarge. The most likely scenario when it's going to enlarge is when you're trying to put in the lens, even though there is no vitreous actually. There is absolutely no vitreous, but still it can enlarge during that time. So make every effort which is possible to get a round regular edge along with the tear. And you'll be surprised that if you can achieve that, how well the lens will be centered for many years.
Yeah, it makes the opening very strong indeed. Okay, fantastic.
Just to add
discussion.
one point,
Yes.
just to add one more point
Yeah.
regarding this. No platform was available till now on how you put a multifocal or a toric IOL in case of a compromised capsule. So one of my friends, Dr. Ashrey Naika from Eye Foundation, he has just developed a bag. It's like a capsular bag, which you can use to put any IOL in it. So it gives you a docking place where you can put any IOL, and then that bag. So it's in almost on the final phase. It will be out soon from Care Group. So you can put the multi-piece or the multifocal IOL in between, and then you can just use it as a typical glued IOL. So there is a dock in which you can just insert your typical IOL, like a Panoptix or anything, and then it will adjust it, and then you can just dock it like a glued IOL. So the dock is there, and it is like a flexible dock. So you can just put the whole IOL and everything inside. It's just an update. Yeah,
that's good. But actually, I wonder why we don't have multi-piece toric lenses. Multi-piece, multi-piece. It's so simple. It is so simple. And why we don't have, that's the irony. I think we should encourage.
The point of discussion,
it's
sir.
difficult to maintain the inventory that way, Deepak bhai. I think The reason why they do not manufacture that in the multi-piece platform is because it actually puts a stress on the manufacturing unit as well. And given a choice for a normal case where it is uncompromised, we do not have any capsular issues, none of us would like routinely plan.
It is a special lens. Let them charge a little bit more, no problem. But if that's a better option than trying to put a lens in a open capsule and other things.
That is the catch.
Reverse optic capture.
That is the catch situation, that many of the aphakia have a lot of astigmatism. Generally, if you are referred a patient of aphakia management, generally you are encountering with -2, -4 cylinder. Generally, and then you have to either.
Most of that is surgery-induced astigmatism, Dr. Abhishek. I don't think
that is
existing.
But we don't have any platform to counter it. Generally, that is the catch situation. That is what we're trying to say.
Okay, so everybody looks like they're droopy, they're hungry, they would like to go back to their dining tables and then crash onto the bed. Unless Shishir has anything more to speak up, I would request Dr. Pranav Ranjan to take up the mic once more, give his concluding remarks, and then we can close the session maybe.
Dr. Abhishek will give the vote of thanks.
Okay.
Dr. Abhishek.
That is no, I think that
everyone for a wonderful webinar, wonderful discussion, and people who have missed it, for them, the whole webinar will be put on the YouTube channel, recorded one. So later on also, if they want, they can watch it. So thank you all the speakers, all panelists, all chairpersons from my side. And over to you, Dr. Abhishek, to wind up the webinar.
So I think it was a wonderful webinar, a lot of discussion. Thank you to our two super duper moderators, Dr. Anurag Mishra sir and Dr. Shishir, for engaging everybody. And thank you to all the learned speakers, Dr. Jayasri, Dr. Sneha, and a special thanks to Dr. Subhas sir, who made such a great presentation. I mean, it was just I thought sir would be the perfect person who could address with his vast experience. It was
a lot of PCR actually. That's why.
No, but it was just that you have such a huge experience that you carry with yourself. And thank you, sir, for accepting when I asked you to please speak. So thanks again from the core of my heart, sir. So thank you. Thank you, chairpersons, Dr. Amit Raj, Dr. Anand Dev, Dr. Amitabh Viswas sir, and Dr. Teni Nadum. Thank you to our panelists, Dr. Salaf sir, Dr. Rajesh, Dr. Ashok Nanda sir, and Dr. Sujay Samanta, and three national and international speakers, Dr. Arup sir and Dr. Deepak Megu sir, for contributing a lot from your heart, and Dr. Lalit Aywan sir. And last not least, thank you, Dr. Pranav sir and Dr. Devasri Das, for interesting me with the duty. I hope I would have justified it. Hope you all had enjoyed this webinar. It was very interesting. Thank you all.
Thank you everyone. Thank you. At the end, I would just like to invite you all to the annual conference, which is going to be held in Kalimpong. The dates are 29th, 30th of November and 1st of December 2024. So all of you are invited, and all of you should attend the ISOC annual conference.
Thank you, sir.
Thank you, sir. Good night, everybody.
Thank you. Good night.
To have the Oxford by my side for you. Didn't get it. The Oxford Dictionary by my side for you.
Was that for me?
That was for me to consult so that I can interact with you.
Thank you, Anurag sir.
Thank you so much.
Today Anurag was quite simple. Not in his original version.
I just saw his flying saucer kind of a thing in his on his Facebook.
I think Shishir, when he came to know Anurag sir, was that he was keeping a dictionary in front of him all the time.
Thanks. It was fantastic.
Good night.
Very, very well.
Okay.
Bye, sir.
Good night, everyone. Thank you so
Nice
much.
seeing you.
Thank
Anurag,
Thank
saw
you.
you after
decades. After decades, sir.
Yeah.
Lovely seeing you.
Thank you, sir. Bye. Take care.
Bye.
Shall we close the live streaming, sir? Pranav sir?
Thank you, Satyajit. And thank you, Ajanta.
Thank you, sir. Thank you very much for giving us the opportunity. Thank you.
Thank you so much, everyone. Thank you.
Raviji, please go offline.
Okay, sir. Done.